Srikanth. Hello.
Sir, good morning.
Good morning, Srikanth. Start చేద్దామా?
Sir, ఒక్క నిమిషం చిన్న లాస్ట్ మినిట్ ఎడిషన్ ఒకే ఒక స్లైడ్ సార్ ఒక్క నిమిషం ఇది మరీ ఎక్స్టెన్సివ్ టాపిక్ అయిపోయింది సో
Topic itself is extensive.
సార్
Topic extensive.
కొంచెం ఓవర్ వ్యూ అలా వెళ్ళడం సార్ రెడీ
రెడీయా?
రెడీ సార్
Good morning, all. Today, Dr. Srikanth is a consultant and head of the Department of Anesthesia and Critical Care. He is going to talk on a very important and very extensive topic of sepsis in trauma, a deadly complication and a deadly combination also. So I request Dr. Srikanth to start the presentation.
Thank you so much, sir. So screen visible, no, sir?
Okay.
And the slides are moving. Yes, sir.
Yeah. No.
Right. A very warm good morning to all. Sorry for the schedule change. First of all, because the ICU has been busy over the past 3 weeks and couldn't prepare in time for a very good topic and close to our heart because we deal with quite a few trauma cases in our hospital. So this topic is actually sepsis and trauma is like we see cases, but generally rare. But when we encounter sepsis and traumatic patient, it will be very difficult for us to treat for the most of the times. So this topic in itself is very extensive because we can't be taking a 30 minutes or 40 minutes of our class time discussing all the sepsis and also all the trauma. So we'll go through a brief overview and what are all the specific features related to trauma patients, especially most of them will be discussing about the orthopedics, but the other traumas also, I didn't find adequate journals, but we can discuss at the end of the class our clinical experience in dealing with these cases at trauma at different sites. So with this, we start the class. Coming to introduction, trauma and sepsis are the most important medical problems of the 21st century that demand renewed attention. Sepsis develops occasionally in trauma patients where 10% of trauma deaths are due to sepsis. The traumatic infections are usually associated with dysfunction of several organs. As you know, sepsis is quite capable of doing that and usually appear early within first 4 days. So generally, the most of the traumatic deaths, if you see, they occur generally within the first 48 hours due to high velocity injuries and other reasons of hemorrhagic shocks or and all. So if the patient sustains that period and then later some complication develops and later on we have to focus more on the sepsis not being the cause for the death of the patient after the initial 48 hours. So while a group of trauma patients suffer from systemic inflammatory response syndrome, another group of patients might present the opposite compensatory anti-inflammatory response syndrome. So coming to the risk factors, obviously high velocity trauma, which can cause the destruction of mechanical barriers, which can lead to more infections at any site of trauma, which is the cause, and exogenous bacterial contamination depending on the site of the accident and all. And the local wound factors will play a major role in like promoting the bacterial growth and infection. So any invasive diagnostic and therapeutic interventions, like what are all the lines you are pressing, how much sepsis you are following, also will lead to sepsis. And poor host defenses, either it can be pre-existing or immunosuppression due to trauma. Trauma itself will cause immunosuppression, which again goes in cycles of it causes infection and it causes further immunosuppression. So that's what we discussed in the previous slide. Initially, due to the sepsis, actually infection, it causes an inflammatory response and the cytokines and everything are released. And on the opposite, scars, what we have seen in the previous slide, compensatory anti-inflammatory response, they are talking about this due to direct effects of trauma. There will be immunosuppression, and which will cause again the poor host defenses and sepsis. So coming to general common organisms, what causes generally this staph epidermidis and staph aureus are on our skin, and they can enter easily inside when there is a high velocity injury and breach of like open fractures or open skull. Either due to surgery or due to injury, they can go in or through implant if during surgery proper, though very rare these days with all the measures we are taking. Gram-positive like staph epidermidis, staph aureus, and enterococcus. Gram-negative bacteria including Pseudomonas, Enterobacter, and Klebsiella species. Opportunistic infections are also quite common in trauma cases where they are associated with trauma. Especially these organisms are found to be more associated with traumatic cases: Clostridium difficile, Candida albicans, and CMV. So how it happens? First of all, the source generally, if the fall at homes or all, generally they carry a very like closed fractures like that. So obviously when you encounter trauma at road or the external dust and infections or all for open fractures, they are a very good source of bacterial contamination inside our body. And also after the admission into hospital, the hospital environment, healthcare personnel who is treating them, the nurses, the environment, hospital acquired it can be, and also the invasive lines we place, the operation we do, anything can be a source for sepsis to set in trauma patients. So speaking to primary bacteremia, it happens at the site of infection, we see post surgical infections, or we commonly encounter in the knee. We see septic arthritis and all post some intervention or arthroscopies also. Sometimes we have seen primary bacteremia, or also and also where the injury actually happened, there a local infection will be there. And secondary bacteremia generally refers to site of infection away from the initial site of trauma, which can be due to systemic bloodstream infection and causing a generalized sepsis. So now comes this very concept of biofilm. Biofilm actually is like once the microorganism makes contact and adheres to the either an implant when you're doing surgery for spine or bones or anything for the trauma. So the bacteria will enter and actually adheres to either to the device or to the bone in case of open injuries. So then they form a biofilm. It's like a aggregation of cells. It forms a layer-like thing, aggregation of cells and cellular products attached to a solid surface or substratum. Then it will be a very beautiful medium for the bacteria to grow, either the bone or the implant, and they will form a very thick layer of around the implant or the bone, which is termed as biofilm. Once the biofilm is formed, then it will be very challenging to treat that infection at the site. So it is resistant to antibiotics, most of the antibiotics, and also to an extent to host defense mechanisms also, such as phagocytosis by leukocytes. So when I was reading about the biofilm, then the line in the Elsevier journal, what on the basis of which I prepared this talk, there has been written a line like this is why the research is going on with implants filled with medication and all to counter this biofilm formation. And when I gone through the supporting articles for what are all the orthopedic implants they are under research, I got through a very pretty exciting step through a bit out of purview of this topic. We'll just go through 3-4 slides of what is happening in the field of orthopedics to counter this formation of biofilm. So this is antibiotic-based coatings. So the implant is basically coated through their vancomycin, gentamicin. So many antibiotics are the most commonly used. One is the gentamicin for antibiotic-based coatings. So that is a microscopic section with the scanning electron microscopy on your right, and the implant coated with gentamicin on your left. So then, sorry. Again, with the antibiotic, the problem of resistance or a period of time is same even with this type of newer technologies. Then came the antiseptic, where they actually act on a broader spectrum, for a wider range of bacteria and all. So the commonly used antiseptics are chlorhexidine and chloroxinol for this one, and it's the scan microscopy where the upper film showing the blocks with saline solution, and then the lower film showing the blocks where they have used 2% chlorhexidine. So if you see on the left one, the bacterial colonization is decreased in the density and all, and also on the right side, if you see the lower one, you can see the chlorhexidine particles attached to the bacterial membranes and causing some sort of disintegration and effective. So then comes this newer technology. They all pretty much, most of them are experimental stages, and some animal studies are going on. Hopefully in coming decade, we can see all these into practical uses of that. So the nano silver coatings, we all know the importance of silver as antibiotic. Even heroin causal does that and adds silver in your soaps. So the nano silver coatings on the implants, which will actually decrease the bacterial contamination once they are infected. So then this phacoactive based coatings on your right, they commonly use titanium oxide. They will display bactericidal effects via membrane degradation after exposing to the ultraviolet irradiation. That's how the phacoactive based coatings work. So then this antibiotic loaded bone cement on the top left you are seeing. So even the bone cement what we use for the replacements and all can be antibiotic loaded. Those nice white balls what you're seeing. And the bottom one is a beautiful concept, like it screws, they are making it a porous membrane, and they're actually filling it with a drug reservoir. So for the controlled release of that. So these screws are dug into the tibial or some anywhere, humerus plating and all these loaded. There's so many other, like I've gone through, like silk screws or some other. So many variants are there in this one. Lot of research is going on in this field. So then this interaction between the surface roughness, they are studying how the surface roughness will actually help or stop the bacterial adhesion actually. So again, there are controversies that some may say the rough surface will actually oppose the biofilm, but there are few other studies that contradicting this one. This is still an experimental phase. And this is electrospinning technology where they will spin like a coat like thing over the implant using this particular machine. PLGA coating with a drug. PLGA refers to polylactic co-glycolic acid. The one in the like more thicker mesh you are seeing is a vancomycin coated spinning, and the second one is no drug. So maybe the dark one works better to stop the biofilm. Then this cutting edge technology of even in this article which was published in 2020, he says we are far away from creating this, but hopefully we will be seeing this soon. And where in all the implants like catheters, we now have drug impregnated, but this integrated biofilms, they're planning for processes, catheter, pacemakers, everything. So there is a level 1 layer and a level 2 layer. Level 2 layer can be actually customized to the bacteria, either empirical or based on the cultures. We can actually customize that second level to the bacteria. So enough with this scientific stuff. Now I will move on again to our regular talk. So the defining sepsis and polytrauma, we are not going again into depths of sepsis, which will take a lot of time for us. So we have come from a very initial days of thinking defining sepsis. It's still a blood poisoning. I do agree. From blood poisoning, then to inflammatory, what do you call as first criteria, we are applying it to sepsis. But the recent 2016 European guidelines were there, and then in 2021 surviving sepsis guidelines, they have updated the definition of sepsis as a life-threatening organ dysfunction that is actually caused by a dysregulated host response to the infection. So it is rather than the pathogen, the most of the effects of sepsis, what we are seeing are actually due to dysregulated host response. Again, from SOFA to QSOFA, SOFA score we all know, and again QSOFA is more useful in trauma cases where we do a quick Q just refers to the quick assessment of sequential organ failure score. And there is a proposal of polytrauma definition by a very well accepted one, which we are seeing in the next slide. So there are CERS criteria, less than 30, but I think there's no need to again read out all those. And Qs of a criteria, we should have 2 or more to define failure, systolic blood pressure, respiratory rate, and GCS less than 14. This is a quick assessment of SOFA score, what they're doing in the trauma cases. And perhaps definition proposal of polytrauma refers to injuries of more than 3 points in more than 2 different anatomical regions, plus one of the physiological. They obviously refers to consciousness, hypotension, acidosis, and coagulopathy, and more, geriatric age more than 70 years. So these are few trauma scores which would like to give more of looking like an ortho and neuro stuff, but we should also be well versed with this. So the 3 most popular trauma scores are revised trauma score, new injury severity score, and the trauma and injury severity score, which is short term as TRIS. So this is the revised trauma score, which I added last minute. That's the permission I took from you, David. So this revised trauma score actually culminates the GCS, systolic blood pressure, and respiratory rate with an RTS values. And that ISS and those are like a bit complicated. Actually, the new injury severity score is actually primarily injury severity score. So the injury severity score, what they do, they have a rating from 0 to 75. And in that, they have component termed as abbreviated injury scale, AIS. So they measure that in all the body regions which are infected which are actually affected by trauma. And in each region, they rate it from 1 to 6. 6 will be termed as unsurvivable traumatic event in that particular area. So if any particular area, the term is unsurvivable grading to 6, automatically that ISS score, injury severity score, will grade up to 75. So the new injury severity scale, what we have seen just in this slide is just the modification of this injury severity scale. They see up to a maximum of 6 regions. So in the new injury severity score, again, the short forms like all our shorthand using smart mobiles and all like this same, decrease the difficulty. So we pick up top 3 injured areas, and we just square their scores. Top 3 will pick up and square the score. That is what you will see in new injury severity score. TRIS is nothing but a culmination of RTS and new injury severity score. I will share the articles regarding this trauma scores and all with you so that you can have a detailed look about it. So coming to pathophysiology behind sepsis and polytrauma, we all know the first hit and second hit concept. The first hit will obviously be the trauma or injury. Second hit can be second hit we commonly refer in whether in fat embolism, whether we are studying about fat embolism and all. The second hit comes the surgery. If it is in the wrong time for the patient, it can cause actually devastating complication. And in this scenario, we can take even sepsis for a trauma patient as a second hit. So the perturbations in several metabolic pathways associated with the hypoxic response of the host, the exacerbated immune system activation, both these are considered as hallmarks of trauma associated with sepsis at the molecular level. So we'll be deeply discussing this pathophysiology of what lies behind the polytrauma sepsis. So in these headings will be their innate immunity, coagulation abnormalities, anti-inflammatory mechanisms, and immunosuppression. So as I said in one of the earlier slides, they both go hand in polytrauma with sepsis and organ dysfunction. So coming to innate immunity, there will be pattern recognition receptors, which are key components of the innate system that get activated after recognition of hazard cells. Something is coming in, some invading bacteria in the bloodstream. Then these receptors of our innate immunity get activated. So what do they recognize in the bacteria? So they recognized motifs expressed by the bacteria, which are termed pathogen-associated molecular patterns and damage-associated molecular patterns. So it is both specific to the bacteria and also to the soft tissue or some tissue damage caused by the invading bacteria and also the trauma. So an important example of these motifs is lipopolysaccharides present in the outer membrane of gram-negative bacteria. And also in case of gram-positive bacteria, there will be lipoticoic acid and peptidoglycans and bacterial DNA. These motifs get recognized by our innate immunity and they trigger a host response system. So PRRs can also recognize molecules considered endogenous stress signals, such as ones associated with presence of trauma, tissue necrosis, or burns, which is what I just mentioned earlier. So coming to coagulation abnormalities, how this play a role? Actually, the function of coagulation in an infection is to surround microorganisms and keep the inflammatory response down to the local area. So they bind it and hold it there. That's the basic job they are assigned, with cytokines that stimulate thrombin formation. So however, just like how we discussed in the definition of sepsis, sometimes it gets excessive. So its excessive activation will lead to negative effects such as fibrin thrombi occurring in the microvascular bed, that eventually contributes to organ failure. So during the inflammatory response of a septic patient, coagulation proteins are consumed, leading to bleeding and at the same time thrombus formation also. So anti-inflammatory mechanisms and immunosuppression. During sepsis, the innate immune system is activated by PMPS and DMPS, releases a series of pro-inflammatory cytokines, a phenomenon recognized as cytokine storm. During COVID, we are well known with this term cytokine storm, or more heard term, so which maintains a severe inflammatory condition. So the activation of PPS produces a series of pro-inflammatory cytokines. We all know interferon gamma, IL-6, and TNF. So since the most important effect of trauma on immune function is inhibitory, parallelly in according to this, immunosuppression also will occur, and this will promote infection and sepsis. As you can see, if a trauma patient lands up in sepsis, there are always these opposing forces acting. So bleeding and thrombus formation, immunoreaction and immunosuppression, and all these will further deteriorate the patient clinical condition, leading to multi-organ failure. So we are coming to that, organ dysfunction. During the last phase of sepsis leading to septic shock, multi-organ failure occurs. The death risk increases by 15 to 20% for each organ failure. With 4 or more organs gone, the death rate increases to above 90%. So the main factors are the microvascular occlusion, disruption of microvascular homeostasis, and the disruption of tissue oxygen transport. Finally, an excess in nitric oxide promotes the vascular instability and myocardial depression, leading to death. Even I am quite unaware of most of these pathological or physiological stuff and have to read more. Maybe seniors' inputs will guide us more in this. So then how do you predict? It can be either clinical criteria, like we all know the SIRS, the febrile spikes, the tachycardia, tachypnea of the patient, elevating counts and all. And then comes the biomarkers which will help in identifying the onset of sepsis at an early period. So So how many of them are actually available? Even I don't. Among this, we can easily identify or test for procalcitonin, CRP is available, and HDL we can measure, HbA1c we can measure. So all these biomarkers actually help in identifying the sepsis a bit early in trauma patients. About the remaining, to see how many of them we can actually test locally in Vizag or available anywhere. So coming to management in trauma, the term damage control, although not a medical concept, was developed to manage trauma, showing massive bleeding, shorten the surgical time, and avoid the lethal triad of hypothermia, coagulopathy, and acidosis. Since polytrauma that includes soft tissue damage and multiple fractures can happen in many forms, mostly because of an accident or a violent event, frequently these incidents take place in septic conditions, and therefore patients must always be considered as contaminated. So this is the DCO protocol, damage control and orthopedics protocol that following. So we all do this, but again, reiterating the routine ones also carry importance, because even we, in spite of how many years we're practicing, sometimes miss out the basic ones too. The history information regarding the mechanism, location, and the timing of the injury, the physical exam, including inspection of the soft tissue damage, the size and nature of the external wound may not reflect the damage to deeper structures. If possible, neurovascular damage is suspected, seek consultation from the vascular surgery department as early as possible. So indication to administer IV antibiotics and tetanus prophylaxis, the indication to obtain radiographs and or CT scans of the injured extremities, the urgent thorough surgical irrigation with a balanced salt solution such as ringer lactate to reduce bacterial growth. Debridement according to the degree of injury, employing the Gustello-Anderson classification, which we'll be seeing in the next slide, and ultimately the fracture fixation or the surgery in case of head injuries and all. So this is the Gustello-Anderson classification, where they grade the size of the wound with how much surgical, how many liters you have to employ surgical irrigation, and an empirical antibiotic therapy. They are suggesting this one. And this is an article published in 2021. So mostly I think this applies to our current what we are treating. So less than 1 centimeter wound, minimal energy trauma, soft tissue damage, contamination or combination, 3 liters of saline solution. More than 2 centimeters wound, it constitutes moderate energy trauma, so 6 liters will be needed. And if it is a large external wound, more than 10 centimeters, so you have to do with a 9 liter saline solution, and you add an aminoglycoside and add penicillin for anaerobic coverage, heavy inflammation. So Wingquist and Hansen classification actually defines this comminution grading, this one. So when the fragments are separated completely, and the problems of again non-union and all happens in someone, again it can lead to avascularity of some fragments and bone necrosis, which can again in turn lead to infection of the bone and systemic sepsis. So which is why the degree of comminution of the fragment is also equally important. So we all try to need to avoid this scenario, which the term failure to rescue. So failure to rescue is defined as death after any recorded complications separated into infectious and non-infectious causes and directly associated with deficient initial management of complications, which include pneumonia, respiratory failure, arrhythmia, and stroke. In this, this does not apply to very sick cases. They come, they die in half an hour, not like that. So this particular failure to rescue, they are talking about our inability to identify the early complications and treat them adequately. Deficient initial management of complications. So in this kind of setting, the multidisciplinary approach plays an important role in trauma care by reducing misdiagnosis and delays of treatment, therefore rescuing patients from developing further critical complications. So the treatment of sepsis always must be examined under 2 main headings: appropriate antimicrobial treatment and an all-purpose supporting treatment. So since during the first 6 hours of any trauma event, treatment is extremely important in terms of prognosis. During this time, antibiotics are mostly given empirically until the specific identification of active microorganisms is achieved. And our Satish sir has sent that beautiful Sanford guide to antimicrobial therapy. So in that, there are like for each and every case, like brain injury, brain abscess, meningitis, also long bone injury, bone osteoarthritis. It has given under separate headings what are all the common pathogens we can identify and what are the common antibiotics that work. And again, once the cultures are out, what are all the specific antibiotics that work? It's very good. I have gone through few of the pages for over the past 1 week for a few of the cases, and it was quite good. I think we can all have a look at that one. So, since like a late administration of antibiotics is significantly associated with an increased mortality rate, especially when associated with hypotension. So this is the SSC guidelines in 2021. So most of them we all know the administration of crystalloid, measure the lactate, apply vasopressors. If it doesn't improve, administer broad spectrum antibiotics and all, and cultures before administering antibiotics. So the take-home points are identify early signs in trauma cases, always take them as contaminated, if not most of the cases. Look out and take care of all preventable factors. Each trauma is different. Understand the trauma, what are all the possible complications it can cause, and areas it can affect, and treat. Follow the surviving sepsis guidelines in case of septic sepsis infecting the trauma cases. Multidisciplinary approach is the key to avoid the failure to rescue scenario. Thank you so much for the patient hearing, and these points I would like to discuss. I would like to take the opinion of all the consultants present here working in different hospitals. What are all the preventable factors we can do to achieve or minimize the risk of sepsis in a trauma case? And what are the site specific site of trauma specific challenges we face generally? Thank you so much. Thank you for the patient hearing.
Thank you, Srikanth. A very good presentation. Very briefly explained what are the possible factors of sepsis and trauma, and what are the risk factors of trauma patients who develop sepsis, and biofilms, and what type of catheters are needed to prevent the infection. So my observation in trauma, particularly head injury patients who had severe head injury and followed by aspiration, particularly aspiration of dust and dust related contaminated mud and dust when the patient become unconscious, and both facial and head injury. So these patients the first day of they usually go on ventilator, intubated and ventilated, and the first day itself you take the ET culture samples. The initial day of admission itself it is growing Acinetobacter. So the reason why the first culture itself showing Acinetobacter is the environment, the dust on the roads contaminated with a lot of Acinetobacter. So majority of the patients, every patient almost, if you take the culture, it is going Acinetobacter. So third day or fourth day, you will get the report, and by the time patient develops fever, so pneumonia, aspiration pneumonia, shall we treat this Acinetobacter or not? Hello?
Sir, I think culture, if the culture is positive with continuous ongoing clinical signs also, it's better, no, sir? What's your take?
Clinical signs also, but the Acinetobacter usually it's the sensitivity pattern is showing sensitive to only tigecycline and colistin. Any input from any others? Hello? Satish? Jekina Mohan sir.
మీరు యాంటీబయాటిక్ గురించి మీరు చెప్తే ఇంకా మేము చెప్పడమే ఉంటుంది సార్.
అలా కాదు అంటే this problem we faced, any inputs from others or any experience from your side regarding this? ఎవరు మాట్లాడలేదంటే
సతీష్ బిజీగా ఉన్నాడేమో.
Antibiotics is a tough call, sir, definitely.
యాంటీబయాటిక్ కాదు. ఫస్ట్ థింగ్, so aspiration is non-preventable. That happened already. So few cases we come across this. So what initially, usually we don't put, no, initially higher
Yes.
antibiotic we don't put. Routinely for aspiration we will put to cover the any ropes and usually put monocept plus clindamycin combination. Ultimately, you will get a report like this, and the patient will have bilateral pneumonia, aspiration, and since this Acinetobacter. So you may change it to another antibiotic like BLI, Piptaz plus amic acid, something else. Later on 10th day, definitely you will get patient will be on tracheostomy and patient get purulent secretions, high grade fever or something like that, and your culture is growing this one. So ultimately on 10th day, after 7th day, you will go on tigecycline and colistin. That is the things are happening like that because we can't avoid this because evidence is showing Acinetobacter. Then we thought, why this Acinetobacter for all the patients? Is it because of hospital acquired infection from spreading from others, or patient itself having that? I discussed with Dr. P. Ramana. He said there is one. There are some few articles regarding the road traffic accidents contaminated with dust aspiration. Ultimately, it grows Acinetobacter. So that is one reason.
This culture report came on 4th day, sir. 4th day like that. sir.
Usually 4th day కానీ 5th day కానీ వస్తే
ఎంత
అప్పటికి వస్తే
కల్చర్
ఆ
గ్రో
time.
అయినా సరే హైపోటెన్షన్ లేకపోతే మనం ఇవ్వక్కలే కదా డేవిడ్. హైపోటెన్షన్ అండ్ షాక్ లేకపోతే మనం ఏం చేయట్లే కదా.
But patient has pneumonia is there, consolidation is there, fever is there.
మనకి as long as patient not having any fever, I mean fever plus
That's what.
hypotension లేకపోతే
Can
ఏమక్కలే కదా.
can you wait till the patient gets hypotension or mods or something else, or
మేబీ ఒక డోస్ ఎంతో ఇచ్చేసి వదిలేయాలేమో అనుకుంటున్నాను నేనైతే మాత్రం. నా పర్సనల్ ఫీలింగ్ దట్ నాట్ టు కంటిన్యూ ది యాంటీబయాటిక్స్.
or will you wait till the time?
చెప్పండి.
అంటే if you wait till patient gets hypotension, the mortality will increase.
అదే
Because,
తెలుసు, అందుకే అంటున్నాను నేను అనేది ఏంటంటే that's what I'm telling you. You just maybe have to give only one dose of this one and wait like మన ఓటీకి ఇచ్చిన prophylaxis dose ఇచ్చేసి వదిలేయాలి అనుకుంటున్నాను.
if you give one dose, is it sufficient? Because patient is already having the infection with Acinetobacter. One dose may not be sufficient. Because it is not a prophylactic dose. We have to treat the bug. It is already aspirated and it is multiplying, growing, and it is going heavy growth of Acinetobacter. So in this scenario, what we did, we treated. We consulted with ID also. We treated 7 days to 10 days, and pneumonia resolved, and patient also improved. But no patient died. No patient, not even single patient died because of this infection in the head injury patients who is aspirated.
Tigecycline ఇచ్చారు సార్.
Yeah, both tigecycline and colistin combination, because evidence is there, patient is deteriorating, so then patient is improved. All these patients who are having this problem are improved.
It's clear, sir. I have a similar Onkar logged out, I think. I have a similar scenario, but on the opposite end. And basically, like some crop of young physicians coming up now. So I don't want to name him or her, but one of the young physicians has sent the case to us. So It's a pathological severe initial ischemic stroke, sir. Then it turned to hemorrhagic transformation, and then it increased, and then we have gone for she is a HBsAg positive, and then she had this CRHD with a severe valvular MS in her 2D echo, and with a very frequent arrhythmias. We 2 times treated with IV cardron, and then she was on vasopressors for some time, then weaned off. And on one day, suddenly on third day, we have started with Monosef, and again the treating physician was very adamant on Pibjo and Delas in this younger fellow. Took a lot of resistance for me to calm them up and tell them I know what I'm doing. Please hold on. It went a lot of resistance for me. And then one day she deteriorated. We ventilated her, and repeat scan showed a midline shift that hemorrhage bleeding inside increases. So the neurosurgeon was on the surgery. The patient went to OT in 1 hour. So it was done. And then on the second day, they're trained in Gangaram, Delhi, and they have some ready protocol of sending for cultures for all. In spite of the patient, in spite of all these, the patient didn't have a single febrile spike, sir. All through the TC was normal, 6,000, 7,000, 6,000, 7,000, no single febrile spike, no tachycardia. This arrhythmia was there, but there was no tachycardia. So then post-surgery, they are like, we are more worried about VAP, forget about brain. So discussing with neuropatient, neurosurgeon and all, I have kept Monosef 2 grams BD. So then this 2 more days elapsed, a lot of fights were going on between the patient. But as you know, even after Dr. Kavita, we are maintaining the same concept of closed ICU in our setup. So I told in between these 4 walls, what I say, we can always discuss cross-table, but this is what happens. She doesn't need it. If there is an early sign of anything, she's in ICU, I will take care of that. So then again, they didn't forget about brain, they were worried about VAP, and then some other infection. And then this beautiful culture report came up. So it showed Klebsiella. And now they want to put a recovering. By that time, the patient was recovering. We were on to TPs post-surgery, tracheostomy. We were like support and TPs alternating. At that stage, that culture report came, sir. So it showed.
Hello. Meet bettandi.
Sir, okay. So at that time, because the topic of culture. Sir, because the topic of culture report came, so I was discussing this case. So at the time when the patient is recovering, this culture report came that blood culture showing Klebsiella species, and they were like worried like hell and want to keep tigecycline. Then when the patient is totally in the phase of recovery, and we are actually planning to wean off the antibiotics and wean her off to room air, and probably planned decannulation also. So they were like hell, and they all asked attendants also to purchase them and all. Luckily, the neuropatient Dr. Devababu stood up with us because he knows how we are treating the cases and all. So we persisted with that antibiotic therapy of Monosef 2 grams, and the patient Klebsiella, it's shown sensitivity to tigecycline, colistin, and all this iron, and they were like keep tigecycline. We have seen the cases. Then that physician was arguing me with that. I have seen some cases day 1 infection, day 2 coma, day 3 death. I told her still 3 days are there for the death to come. At the earliest sign of sepsis, you don't need to ask, I will only keep. So yesterday, the patient was decannulated. She's completely fine. And till now, touch wood, there is no febrile spike, and even the arrhythmia stopped with the treatment of, we followed it with oral cardron, I mean like through rice tube cardron and all. So this case improved. And another case also, we have seen a similar pattern with the same physicians. Even in that case, the attendants were fed up and they ditched that physician, and then we switched to our Santosh Kumar sir. So he removed all the antibiotics and all, and that patient also tremendously improved. So, but in your case, again, the patient is sick. He or she is having pneumonia and deterioration. Then we can give that definitely. But I personally feel if there are no signs of sepsis just based on culture reports, I think treating a non-existing infection is like maybe controversial. I think maybe some seniors in critical care can help with this scenario. Lucky, I don't say it's lucky. It took a lot of guts and effort for me, because when Kavita madam used to stay, she's the part of management, but I am not part. So putting up a tough fight and brave front is a bit difficult task for me over the past 2 weeks. That's why the class also got delayed due to all these discussions and all. Fortunately, both the patients settled and one of them shifted to room and another is ready to shift to room. But this is the scenario I feel. So if, as the patient is in ICU and we will be monitoring continuously, if there are no signs of sepsis and we are not sure of clinical infection, I think we can wait, sir. But it's like in your scenario where the pneumonia is there and it's worsening, and we have a proven bacteria, I think it's better to give a shot of that antibiotic. That's my personal feelings.
But really, I'm sorry for keeping my mic on by unknowingly. And thing is, really, you have a guts and to do that is very nice, but very difficult. Even my colleagues are putting antibiotics very fast. Even yesterday, one patient with tension pneumothorax with post-KT transplant, we were at shock and we were only thinking about septic, and changed immediately antibiotics. Finally, we have to put ICD and patient improved immediately. So even the previously one more patient, Sridhar also, when patient was in ECMO, same thing. Everybody's thinking about only the sepsis. Because since penicillin is derived, from that time we are fond of antibiotics, we only want to give antibiotics. But after some time, now stopping of antibiotics is becoming a very tough job, because we will, when you look at the pro and cons, we look at the pro side better than the con. So most of the times we would like to, okay, we'll give one shot. Now, as David said, only one shot is enough. So that thought process, that thinking will have to change a lot. But only thing is not the cultures. Even when the patient is on steroids, your total count is very high. So I always feel that there are 4 things to combine for a sepsis. One is a total count. Second is any clinical sign of sepsis of fever or anything. And the third thing is even if the temperature is there or not there, WBC count, and not only the total count, in the peripheral smear, CRP, procalcitonin, all put together, we should consider as a sepsis, is my opinion. Because most of the things we know, a lot of studies, CRP is not at all single point of this one. And procalcitonin is not useful for the starting. It's only for stopping or reducing. That's what what I learned. So I feel that that's one real tough thing. All 4 things to be done, looking at the temperature, then thinking about if the patient is not having any signs of sepsis, because as David said rightly, you cannot wait for hypotension, maybe you're delaying it. At the same time, other 4 points are important. So thank you.
Yeah, procalcitonin is increasing, CRP is rising, counts are increasing, patients showing signs of sepsis like fever, hypotension. Definitely, we have to treat that one. Otherwise, the patient is stable, only culture is growing, no other signs, procalcitonin is normal. You can wait, I think. But
even procalcitonin have a lot of pitfalls now, David sir, because so many times, because post-operative you cannot see, cardiac you cannot see, and there are renal you cannot see. Lot of places even procalcitonin so wrong. So I feel normally you do procalcitonin twice at least. That means twice means you do today and tomorrow again. So if it is increasing, then only you think about. That's what is my feeling.
yeah, that is for escalation or de-escalation of antibiotics. So not only procalcitonin, we look at all the sepsis parameters.
Even my colleagues also starts a lot of antibiotics, sir.
Yes, sir. Antibiotics is always a controversial topic. There, so many have different school of thoughts. Anyway, one patient is deteriorating, there is no alternate other than starting or continuing.
The
Patient is
question comes
stable.
here, David sir, the question comes here is that when to start is a question, and second question comes is whether we can stop it. These are the only two questions we are really fighting now, sir.
Yes, sir. It may be contamination also because of ICU, the way they are taking the cultures, any contamination, and the colony count, all this to be considered. If any controversy, any issues, you can take the ID helps all. ID help. Sometimes ID people will come and they will ask to stop the antibiotics also. So this is all
And
a
most of the, whenever we call ID, they normally try to put antibiotics. Sir. The stopping antibiotics, change of antibiotics may be there, but stopping of antibiotics, ID considers normally I have not seen.
yes, sir. It all depends on patient clinical picture. Any questions? If there are no questions, thank you, Srikanth. Nice presentation and nice discussion. Thank you for your active participation. Thank you, Srikanth.
Thank you, sir.